We are the Association for Child and Adolescent Mental Health, or ACAM for short.
Hello, my name's Matt Kempen. I'm the Marketing Manager for ACAM, and welcome to the second podcast we're releasing this week to celebrate Eating Disorders Awareness Week. Today you'll hear from Dr. Caitlin Lloyd of Columbia University in the USA on Anorexia Nervosa. Earlier this week we released a podcast with Dr. Michelle Sader of the University of Aberdeen in Scotland on the topic of ARFID, so do please check that out. As well as these podcasts, there's a host of other free resources such as talks, video abstracts, blogs and a topic guide on eating disorders, so do please visit www.acamh.org. And now, on with the podcast.
Hello, I'm Clara Faria, an ACAM Young Person Ambassador, and in today's episode, I have the pleasure to talk to Dr. Caitlin Lloyd. Dr. Lloyd is a postdoctoral fellow at the Columbia Center for Eating Disorders. Her research focuses on neurobiological mechanisms in eating disorders. Today, we will be discussing her paper, Food Choice and Neuro-Reward Systems in Adolescents with Anorexia Nervosa and Atypical Anorexia Nervosa, which was published in the JCPP. Welcome, Dr. Lloyd. Thank you so much for being here today. Can you start with an introduction, giving a short overview of what you do?
Hi, well, it's really great to be here, and I'm really excited to discuss my research with you today. So, as you mentioned, I'm a postdoctoral research fellow at Columbia in the Eating Disorders Research Unit, and I have a long-standing interest in the neurobiology of eating disorders and have primarily been studying, I guess, for almost 10 years now, the neuromechanisms of anorexia nervosa. And so in our lab, what we do is really try to look at the brain differences that might be present between patients with eating disorders, such as anorexia nervosa, and individuals without eating disorders, both in terms of their structure and function. And then we spend some time trying to really characterize the core disturbances in eating behavior and use tasks that capture those disturbances and then link those back to the underlying brain mechanisms using technologies like functional MRI.
That all sounds fascinating. I know sometimes, looking at neurobiological mechanisms behind certain diseases can hopefully lead to new targets for drug intervention. And focusing on your paper, you looked at certain brain regions and you hypothesized that their activation patterns would be different in adolescents with anorexia nervosa compared to healthy teens. Can you tell us a little bit more about the rationale of the paper and why it doesn't matter to investigate neurobiological mechanisms of eating disorders?
I guess, first of all, there's really good evidence that eating disorders involve disturbances in the brain or sort of brain differences, which is kind of in contrast to perhaps what was thought a bit earlier in time, which was that these illnesses were really primarily kind of sociocultural in nature. And we also know that eating disorders, and so, for example, anorexia nervosa, are kind of characterized behaviorally by disturbances in decision making. So, for example, there's a persistent restriction of food intake, a persistent selection of low-fat foods over higher-fat alternatives that is really coming at the expense of kind of physical and mental health. And so we also know that decision-making is driven by the brain. And so it stands to reason that maybe there are differences in underlying brain circuits that might be contributing to these disturbances in eating behavior that we're seeing in these patients. And the reason we wanted to look at adolescence is because we know that eating disorders typically emerge, and particularly anorexia, around sort of mid to late adolescence, so in the kind of 15 to 19-year-old period. And so we think it's really important to try and capture differences in the brain that might be driving restrictive eating earlier on in illness, when we're able to parse apart the mechanisms that might be contributing to the restrictive eating versus changes in the brain that might have occurred because of a long-standing period of illness. So the effects of malnutrition, for example, which we know do change sort of structure and potentially function of the brain as well. And our particular paper was looking really at reward systems, so the role of kind of heightened activation within reward circuits when a person is deciding what to eat. And that's really based on the hypothesis that perhaps earlier on in illness, so when people first start engaging in restrictive eating behavior and relatively shortly after their initial diagnosis of anorexia nervosa, that the thing that could be driving that behavior is the reward system. And so this idea that maybe it's become rewarding for a person to engage in restrictive eating. Perhaps that's because they're getting reinforcement from people around them in terms of the weight loss being a good thing. Maybe it's because it's making them feel good in some way or alleviating kind of negative emotions like anxiety. And so our hypothesis that we wanted to test was really, is there differential activation within that reward system at the time that somebody is making a decision about what to eat in patients with anorexia nervosa relative to somebody without the illness. In this study, we were really able to look at people relatively early on in illness, which is quite unusual. And the patient participants were within their first year of diagnosis, which is quite an unusual thing for studies of anorexia nervosa.
Yeah, and I think the fact that you used patients who were early on in their illness just adds to the value of that study. So in your study, Caitlin, you used, as you said, the food choice task to test those neural mechanisms of choice among adolescents. And can you tell a little bit to our audience what this task consists of?
So the food choice task, or variants of it, has been used in several different studies of eating behavior, and it's well validated really to capture somebody's food preferences, as well as to be able to index those brain mechanisms that are driving those food preferences as well. And so what happens in this task, it has 3 different phases, and in the first one, the participants rate 76 different foods, and they're presented individually. So on one trial, you might see a picture of a cake. In the next trial, you might see a picture of some carrots, and the person rates how tasty they think each of those food is on a scale of 1 to 5, 1 being not tasty and 5 being very tasty. And then the participant does exactly the same thing, but for healthiness. So they're then rating each of the foods for how healthy they think they are, again on a scale of 1 to 5. And this allows us to then identify one food that the participant has rated as kind of a neutral, so a 3, on both tastiness and healthiness. And that food we then select as that person's reference item. And then in the third phase of the task, they complete a series of choices. So actually 75 trials where they choose whether or not they would rather eat their reference item food or each of the other 75 food items. So for example, if their reference item was crackers, they would then choose between, on trial 1, crackers and cake, on trial 2, maybe crackers and carrots. And what's really important is that they know that one of these trials is going to be selected at random. And so they will actually be asked to eat the food that they've selected on that trial, which makes the task then incentive compatible and makes it more likely that somebody is responding really in line with their true preferences. What it also allows us to do is, because half of these foods are sort of high fat, where, at least 30% of the total calories is derived from fat, and half of those are low-fat foods, we can identify the extent to which somebody is willing to eat a high-fat food on the task and the proportion of high-fat choices that they make. So how often they select those high-fat foods over the reference item, and then similarly for the low-fat foods, how often they're selecting those over the reference item. And this correlates very well with eating behavior in patients who have anorexia nervosa. So that is, the more restrictive eating somebody displays in a meal setting or kind of self-reported restriction correlates very strongly with the extent to which they'll select high-fat foods on the task. So the more restrictive they're eating, the less likely they are to select those high-fat foods. And so it's a really good indicator of restrictive eating behavior. And that's really important because when we administer this task then in the scanner, in an MRI scanner, we're able to see the brain activation that's linked to the decisions that somebody is making. So that's underlying that choice behavior, and to see in particular what brain circuits might be driving sort of a more restrictive pattern of food choice at the time of decision making.
That's super interesting, and thanks for such a comprehensive explanation. And in your paper, in your study, your hypothesis was that you would observe more activity in this region called nucleus accumbens of the brain in adolescents with anorexia nervosa compared with controls. Well, considering all this rationale of the study, which you just explained to us, I wondered, can you tell us about the headline findings, and did the findings confirm your initial hypothesis?
The hypothesis was, I guess, on the basis that we think there might be sort of heightened activation within reward systems that's driving restrictive eating. And the nucleus accumbens is part of this reward circuit. It's very well known to be implicated in kind of reward-driven or motivated behavior. And so we were expecting that this might be more active at the time of food choice, and so more driving those choices of patients with anorexia nervosa relative to healthy controls. We actually did not find evidence to support that hypothesis. So the nucleus accumbens was engaged during food choice in both the patients and the controls, but it seemed to be associated with choice preference, so how much somebody wanted something. What that means is it was more active if somebody wanted the food more or had a higher choice preference for that food. And that was the same in the patients and the controls. So it didn't seem to be differentially engaged. And the extent to which it was engaged was also not related to restrictive eating or the selection of high-fat foods in the task. So contrary to our hypothesis, it didn't seem to be associated with restrictive eating in our patients with anorexia nervosa, so not in line with the hypothesis. We did also look at another region, which was the anterior caudate. And the engagement of the anterior caudate is thought to reflect a kind of shift from perhaps reward-driven eating behavior to a more habit-based eating behavior in adults. So that is, whilst a person might initially engage in restrictive eating because it's rewarding, with repetition over time, that behavior might come to depend no longer on reward-based circuits, but actually on those circuits more implicated in habitual or automatic behavior. And therefore, the restrictive eating in anorexia nervosa might actually be sort of more automatic and less thoughtful and goal-directed, which might make it then really hard for a patient who's very motivated to recover to kind of eat in a way that's consistent with recovery and weight gain in particular. And so having found this anterior caudate region which is associated with sort of automatic behaviors, to be more engaged during food choice in adults, we also wanted to see whether this was engaged sort of earlier in the course of illness in this adolescent sample. And whilst we didn't find statistically significant differences between engagement of this region in patients versus controls in our adolescent group, we did see that the more this region was engaged in the patients, the more restrictive their food choices, so the less willing they were to eat high-fat foods, which highlights to us again the potential role of this region in restrictive eating in anorexia nervosa.
No, that's fascinating. And I think that also aligns with what we know clinically about anorexia nervosa. Like, it's well known that after 5 years of illness, the rates of recovery are so much lower. And it's really interesting to see how that relates to the neurobiology of illness, having, like, as you just explained beautifully, more consolidated circuits that are associated like with habit formation in patients who are adults and will likely have more years of illness. Well, going back to your study findings, well, as you just mentioned, and that's actually something I think it's fascinating about your study, is that you had a null finding. So your results did not confirm your initial hypothesis. And you've just explained to us about the caudate, the anterior caudate, and you just mentioned that in your study, you found that that activation of that region was associated with more restrictive choices, but it was not more activated in adolescents with anorexia. And I was just wondering, how did you make sense of these findings? You just explained a little bit, but do you think that you might, like the anterior caudate might be then a marker of maybe illness severity?
So that's a great question. And I think we're kind of still trying to make sense of it too. But firstly, I think one important thing to note is that we, having not found kind of statistically significant differences in patients versus controls, we then used a slightly different method, so a Bayesian statistical method, which allows us really to test whether or not the null hypothesis, so that is there being really no difference between patients and controls, is true, which is something you can't do with standard statistical tests just because of the way in which the theoretical basis of the test is working. And what that showed for the nucleus accumbens was that there was good evidence that we should be accepting the null hypothesis, so there really being no differences between patients and controls in activation of that reward region. In contrast, in the anterior caudate, there actually wasn't strong evidence for us being able to accept the null hypothesis, suggesting that actually a bit more data was needed for us really to be able to rule out no difference in that region. And so that probably points to there being, as you're kind of thinking about, perhaps there being individual differences in the patient group themselves, which is well supported by our data too. So there was variability in the activation of the caudate in patients with anorexia nervosa, some of whom were showing sort of engagement during choice and some of whom were not. In terms of what that might mean, it could mean, of course, yes, that maybe it's related to duration of illness. So the longer that the illness continues, maybe there is a shift to a different type of circuit. Alternatively, it might mean that there are differences when somebody is initially diagnosed, that some people are showing kind of a more dependence on that caudate region than others. And maybe that's prognostic. So meaning that people who engage the caudate more at this baseline or earlier on in illness are more likely to have a longer illness duration, potentially. And what's nice about this study actually is that this is something we're able to test because it was a longitudinal examination such that the patients are being followed up 1 year and then 2 years after their initial scan. They're having a repeat scan and they're also redoing the food choice task. And we're also clinically evaluating them to be able to see, are these baseline differences in brain activity actually predicting longer term outcome?
Well, thank you so much, Caitlin, for sharing so much about your study. It is really fascinating, and I think when your longitudinal study is published, it will answer some very pressing questions on the neurobiology of anorexia. Still on your study, so you mentioned you looked both at patients with anorexia nervosa and atypical anorexia nervosa, and I was just wondering, do you think that might have been, one potential explanation why you didn't find any differences in the region you're looking for? Considering that in a typical anorexia nervosa, we don't have the severe weight loss that sometimes we see in patients with a typical anorexia nervosa.
Yes, this is a great question that did come up somewhat in the review process as to whether some of those differences that we were not seeing was maybe because our sample was including individuals with atypical anorexia nervosa. To address this question, we reran the analyses not including those individuals, so excluding the individuals with atypical anorexia nervosa, and we actually found the same thing. So there's still no evidence for the group difference. Again, not being able to accept the null hypothesis for there being no group difference in that caudate region, and similarly with the nucleus accumbens, there was again no difference in that region when we just include individuals with anorexia nervosa. And I should say as well, the associations between brain and behavior, so the activation of the caudate being kind of negatively correlated high-fat food choices, were also still seen when we included only those individuals with anorexia nervosa.
Well, thank you so much for that additional explanation. And to wrap up, I would like to ask you, where would you like to see your field go next? Is there any particular area of neurobiological mechanisms of eating disorders you think we need more research on?
Yeah, so I think it's a really important time for the field, as there's a huge growth in the availability of tools for neuroscience that are allowing us to kind of visualize the brain in different ways, both structurally and functionally. And also there's an emergence of kind of new paradigms and statistical methods that really allow us to better test specific hypotheses about the mechanisms of illness. And I think there's so many different valuable lines of potential study. I spend a lot of time thinking about this, but I think one that I'm particularly excited about is really trying to understand how somebody uses different information, both about food, so tastiness, healthiness, caloric content, as well as about future goals, which may or may not involve recovery, and how they're able to pull in all of that information to construct value representations that we know guide choice. And I think the reason I'm particularly interested in that is because in some cases, there's not differences in the way in which value information is represented in the brain. So this activation that's associated with choice, but the value that's ascribed to different food choices, let's say, it is quite markedly different between patients and healthy controls. And what this approach might allow us to do is to better understand those circuits that not only are contributing to different choices, but are underlying different affective responses to food, like eating-related anxiety, for example. And then I think sort of building onto that, we might be able to look at how do we change both the information and processes that are being used to construct those value representations, and are there differences in how modifiable those processes might be in patients and healthy controls. The idea being really just to try and expand our set of evidence-based targets for treatment that can allow us to quantify the impact that our treatments might be having on mechanisms, and hopefully to improve the outcomes of treatments for our patients as well.
Well, that's really fascinating. And thank you so much, Dr. Lloyd, for sharing your research with us today. And for more details on Caitlin's work, please visit the ACAM website, which is www.acam.org. Also, we're going to link Caitlin's profile on Columbia here on the page of this podcast if you want to check out more of her work. ACAM is spelled ACAMH. Do keep an eye out for other podcasts, and don't forget to follow us on your preferred streaming platform. Let us know if you enjoyed the podcast with a rating or a review, and do share with friends and colleagues. Thank you so much for the listen.